Well, good morning, and thank you for the opportunity to provide this presentation to you today. My name is Dr. Kevin Holcomb. I'm a practicing GYN oncologist, but I also serve as the chair of Obstetrics and Gynecology at the Zucker School of Medicine here at Hofstra, Northwell. And I'm the chair of Obstetrics and Gynecology at both North Shore University and Long Island Jewish Hospitals. And I really want to thank the Ovarian Cancer Research Alliance for allowing me to discuss what I consider a very important topic, which is cancer genetics and personalized cancer prevention. First, these are my disclosures. The thing about cancer genetics is, and what I find really exciting about it, it's all about prevention. And this statement that prevention is better than cure was actually attributed to Erasmus, and he's in the 15th century. This Dutch theologian was already aware of this, and I think we all know this to be true. But when we think about cancer, the thing that's really exciting is that often the things that we need to employ to really maximize prevention are simpler things that we already have available to us, as compared to the things that we need to cure a cancer, which sometimes, requires a much more in-depth understanding of the cancer process and newer, the immunotherapies and targeted therapies. And so preventing cancer, we've got a lot of tools already in our hands, and we just need to learn how to use them better. So in this talk, I would like to review with you just how we estimate risk of cancer. And I'm sure many of you are aware of specific germline mutations, but I want to go beyond that and talk about cancer risk assessment just in the general population, how it should be done, and then how we use those results to tailor cancer prevention based on our findings. So, to talk about the scope of what we could achieve here, we have to start off with the fact that 40% of the United States population will develop a cancer over their lifetime. Part of this is success of extending a lifespan and folks living longer than they did in the past, but that's a large number. That's nearly half of Americans. And that risk will go from low to high depending on a number of things. You have to consider one's personal history, their family history, and then genetic risk of currently known predisposition genes. And I want to walk through how we use all three of those. So starting off, you look at the general population for a cancer risk assessment. When does this happen? Well, technically, this should be happening every time you see a doctor to some extent, because they should be asking you questions that can be included in some form of a formal cancer risk assessment. So in my practice, if a woman comes to me with an abnormal pap smear, even though that's why she's being sent, I take the opportunity to ask questions because sometimes there may be a bigger concern than a low-grade pap smear that she walked in with. So I'm going to ask questions about her personal history, the age, BMI, menopausal status. How old was she when she had her first delivery, if any? I'm going to ask about the family. And really, you should be taking a three-generation pedigree, asking about family members with cancers that are known to be part of predisposition syndromes. And you'll know if a cancer risk assessment is happening if people are asking you these questions, and then drilling down further and maybe asking you, well, what age was that person when they delivered, when they were diagnosed with a cancer? And so if you're not having these questions asked of whether it's your PCP or your GYN, you're probably not getting a cancer risk assessment, and you should ask about that. Because the National Comprehensive Cancer Network gives very clear guidelines about when people should be tested for genetic mutations and whether they should be considering doing enhanced screening or other risk-reducing measures. So this is the first step to determine whether you need those things. So again, going back to the general population, if every person in this country underwent a comprehensive cancer risk assessment, it's estimated that about 25% of people have a significantly increased risk of hereditary cancer that would be picked up. Unfortunately, right now, the majority of these people remain unidentified. That's true in the general population. It's even worse with special racial, ethnic, and linguistic minorities because they're less tested. And these are missed opportunities for cancer prevention, and they're very costly missed opportunities, often paid with lives lost. And before you think that this only happens in bad hospitals or in uncaring settings, I can tell you that's not the case. It happens in the best of hands. My colleagues and I in 2020 published this paper at Weill Cornell when I was there, and we showed that there was disparities in why people were referred for genetic testing. We showed that Black women, for example, were much more likely to be referred for testing once they already had a cancer. And white women were more likely to be referred for testing based on the cancer family history before they developed a cancer. So that's a missed opportunity for cancer prevention. So, what are the common hereditary syndromes? I'm sure you all know some of them, but I guess the thing I want to get across is that even the hereditary predisposition syndromes we know are becoming more personalized. And what do I mean by that? Well, BRCA1 or BRCA1 is a well-known cancer predisposition gene. Cancer predisposition genes are almost always what we call tumor suppressor genes. These are genes that, if they're working normally, they would prevent you from getting cancer by one mechanism or another. But once they become mutated, it doesn't mean you're guaranteed to get a cancer, but your chances compared to baseline just went up. And let me show you how this manifests in BRCA. So you can see here on the left side, the general population risk estimates for breast cancer, ovarian cancer, pancreatic cancer, and prostate. Just looking at this, you'll see breast cancer and prostate cancer are very common in the US population. About 1 in 8, 1 in 9 women get breast cancer. Same can be said of men with prostate cancer. And then you've got these two relatively rare cancers, ovarian cancer and pancreatic cancer. But if you have a deleterious mutation in BRCA1, one that knocks out its function, the chance of breast cancer goes up significantly. It's greater than 60% by the age of 70. Ovarian cancer goes from being this rare thing at 1% risk to a not rare thing, somewhere between 40 to as high as 60% in some studies. The pancreatic cancer risk goes up to about 3 to 5%, which is significantly higher than baseline, but overall not a high number. And the same can be said about prostate cancer, which goes from being within the range of, in some studies, of what background is to higher than background, up to 25%. A few special caveats. If you have a BRCA mutation and you've already developed a breast cancer, you can get a contralateral, meaning on the other breast, a cancer, and that's about 30 to 40%. That's important information to consider when you're determining how you'd like to undergo risk reduction. Male breast cancer is pretty rare, but it is increased in BRCA1. And now there's new data suggesting that women specifically with BRCA1 likely have an increased risk of uterine cancer as well. And not the typical lower grade uterine cancer, but something called uterine serous carcinoma, which looks very much like ovarian cancer and is more aggressive. And then there's this question of melanoma, whether that's actually increased with this mutation as well. Moving on to BRCA2, same background risk estimates, you can see the breast cancer risk is about the same, greater than 60%, very common. The ovarian cancer risk is higher than baseline, much higher, but still lower than BRCA1. The pancreatic cancer risk is higher than baseline and higher than BRCA1. And the prostate cancer risk is higher than BRCA1. So just knowing you have a BRCA mutation, you really need to know which type you have. The contralateral breast cancer risk is still elevated. The male breast cancer risk is higher than what's seen in BRCA1. And now you not only have a question of does it cause melanoma, but there's a question of whether it causes ocular melanoma as well. This shows how personalized genetics is getting. Each mutation has its own risk risk estimates of these different diseases. Moving on to Lynch syndrome. This is something when I was in medical school, the name had been changed from honoring Henry Lynch, the doctor who discovered it first, to what was called non-polyposis colon cancer syndrome. And I think you can see why we went back to Lynch syndrome. That's hard to say. It increases the risk of a number of diseases: colorectal cancer, uterine cancer, ovarian cancer, gastric cancers. And you can see by how much. Very high rates of colorectal and uterine cancer, ovarian cancer, and gastric cancer. And again, you have to specify what type of Lynch syndrome do you have. And I say that because Lynch syndrome is caused by a mutation in one of four different tumor suppressor genes, either MLH1, MSH2/EpCAM, MSH6, and PMS2. And so when you look at the risk estimates of endometrial, ovarian, and colorectal cancer, you'll see that how you're canceled is heavily dependent on which mutation you carry. If you have an MLH1 mutation, you can have as high as 20% risk of ovarian cancer, but only a slightly increased risk of ovarian cancer compared to background. That's important to know. If you have, look at colorectal cancer risk, PMS2 has much lower colon cancer risk than MLH1. Obviously, that impacts cancer prevention strategies once you're diagnosed. So again, if someone says, I have a BRCA mutation or I have a Lynch mutation, you have to go deeper and find out which mutation they have to truly personalize to counsel them, one, and then to personalize the cancer reduction process. And then it's really important to recognize that all the answers are not going to come through genetic testing. I think you can all appreciate that the number of cancer predisposition genes is growing constantly. And so there will be people who have an increased risk of cancer, and we can't find a known mutation to explain it, but we can estimate their risk based on other things. So again, if you have a cancer risk assessment of the general population, for example, about 10 to 12% of people have an increased risk of colorectal cancer. That's fairly high. 10% of people have an increased risk of breast cancer, and about 4 to 6% of people have an increased risk of pancreatic cancer. Let's look at those folks with an increased risk of breast cancer, that 10%. Well, the number of genes that are increasing the risk of breast cancer has been increasing. We've known about BRCA1 and BRCA2, but now you have the Lynch syndrome genes added there. You've got PTEN, RAD51C, RAD51D. What we know about these other genes is that they all play a risk. Many play a role in other functions that prevent cancer from developing. They're cancer tumor suppressor genes as well. And so to pick up all the people who you can to maximize the chance of identifying somebody with an increased risk of cancer, you can't just do genetic testing. You have to take a full history. And we have a number of risk assessment models that can tell what a woman's risk of getting breast cancer is. They all take into account the woman's personal characteristics, their reproductive history, and then to certain degrees, they incorporate other information like their reproductive history, their personal medical history, and genetic testing in the case of the Trier-Cusick model. Well, why is that important? I don't know if you all are aware of the case of Olivia Munn, the actress, who I think did a really big service by speaking about her own personal experience with breast cancer. And on her Instagram page, she outlined exactly what happened to her, and you can see the issue. She had normal mammogram screening. As late as January 2023, underwent genetic testing in February 2023 and was told she had zero chance of genetic cancer. I doubt that's what the doctor told her exactly, but she was not at high risk after that testing. But after she did the Cusick breast cancer assessment score and it was elevated, she went on to get extra tests that she wasn't getting, like a breast MRI, which led to an abnormality in a biopsy, and she was diagnosed with bilateral breast cancer by April 2023. This is just 3 months after having a normal mammogram, and it shows you the importance of using those risk assessment scores from those models in addition to genetic testing. So if you look at any population of women and you find that they have, they're all being recommended at certain ages, routine screening with mammogram that has been shown to decrease death rates from breast cancer. But if you have a significantly increased risk, things are going to be added on. For example, for Olivia Munn, it was an MRI that picked up her cancer. And that's been shown to be helpful if somebody has a calculated risk greater than 20% lifetime, or somebody has a known BRCA 1 or 2 mutation. Some patients won't test or haven't tested, but they know there's a first degree relative in their family with a BRCA 1 or 2 mutation. They should be getting MRIs as well. Anyone who had chest radiation before the age of 30 years of age, sorry, should be getting it. Um, and then you have these areas where the risk is increased of breast cancer, but we're not quite sure whether MRIs help. And that would really be a personal history of breast cancer or a precancer like ductal carcinoma in situ, or somebody who has extremely or heterogeneously dense breasts. We know their risk is increased. We can't quite prove yet that MRIs make a difference in their case, but you can see how we can start personalizing your screening by adding additional testing when we know you're at increased risk. Looking at that same population of women who are getting mammograms and MRIs, it's been shown that that combination of enhanced screening is beneficial. It increases the likelihood of you being picked up at stage 1. It decreases the likelihood of you being picked up with advanced stage. You're likely to have a smaller tumor size in an MRI detected cancer. And all these things translate to improved survival, which is the whole point of cancer screening in the first place. Let's look at pancreatic cancer risk. 4 to 6% of people in the general population will be found to have an increased risk with a comprehensive cancer risk assessment. And we know a number of genes that increase your risk of pancreatic cancer that could be picked up on testing. Patients with greater than one first degree relative and greater than one second degree relative with a history of pancreatic cancer on the same side, even in the absence of a mutation in one of these genes, can undergo screening. Now, I say can undergo screening because we don't have definitive evidence that screening for pancreatic cancer actually decreases mortality. There's some good evidence that it can cause stage migration. What if you picked up during a screen, you're more likely to be early stage, and that's definitely a step in the right direction. Looking at colorectal cancer, 10 to 12% of people have an increase of colorectal cancer. Again, the number of genes, including the Lynch syndrome genes, that it can increase your risk of colon cancer. But even outside of that, if you have one or more first degree relative with colorectal cancer at any age, you should be getting colonoscopies beginning at 40 years of age, so earlier, or 10 years earlier than the earliest familial colorectal cancer. So you can see genetic testing is important, but you have to consider the family history to really determine how to best use cancer screening tests. So the genes and the predictors of cancer you can see are getting more complex. What about the testing itself? Well, that has definitely become more complex. In 1900, that's when Dr. Lynch looked at this family, we called Family G, and did a three-generation pedigree and determined that this family was at increased risk of colorectal cancer based on the number of people who were affected. No genetic testing obviously available at that time. And so it was just a pedigree. This is still important to this day, taking a careful pedigree. But by 1990, genetic testing had become useful in clinical care. And so we were able to test for BRCA1 and then BRCA2 and then Lynch, but this was very slow testing. The type of DNA testing, it was very slow and very expensive. By 2008, the government realized that genetic testing is here to stay. It's going to become part of clinical care, and there had to be some protections for folks. And so the Genetic Information Non-Discrimination Act was passed by Congress in 2008, and it says that a insurance company can't deny coverage to somebody or even charge them a higher premium. An otherwise healthy person who has a predisposition based on genetic testing has to be treated the same as everyone else. In 2013, there was a monumental lawsuit where a genetic testing company, Myriad Genetics, had attempted to patent the BRCA1 gene. They were defeated, and it was determined that you can't patent a gene. And that brings us to today. Now, uh, what happened over this time frame is that the speed and the cost of genetic testing, uh, the speed went up and the cost went down significantly. So from 1990 to 2013, it would cost you about $3,000 to get genetic testing for a single gene. But in today's genetic testing, you can do about 90 genes at a cost of $250 because of next generation DNA sequencing techniques. So this is again a slide showing you that difference. After that case in 2013, genetic testing moved almost entirely to panel testing. And so with one sample of blood, rather than just check for BRCA, you can cast a very wide net across a host of known cancer predisposition genes. Now, there's pros and cons to doing that. The pro is that by casting a wider net, you may identify more actionable mutations, meaning a mutation that has proven benefit for increased screening or some sort of risk-reducing surgery. Um, the downside is there are many genes and many alterations in those genes that we don't really know what they mean. And so you have a finding that is different. The gene doesn't have exactly the same coding as someone else's, but we don't know if that means that the gene doesn't work. And those are called variants of unknown significance. And giving a patient a diagnosis of a variant of unknown significance is potentially causes a lot of anxiety without any plan of what to do with those results. And so I think going to a doctor who's comfortable in genetic testing and counseling will help them craft a genetic panel that's right sized for you, not casting too wide of a net and increasing the likelihood of telling you information that's not helpful but potentially anxiety provoking, and too narrow where they miss an opportunity for an actionable mutation to be picked up. So, how can identifying genetic mutations help patients? Well, we already mentioned these changes that can happen once you've been determined to be at increased risk. They can be changes in screening, like adding a MRI of the breast. It can be changing the age at which you start doing screening, like dropping the mammograms down to 30 years of age. There are a number of medications, some of them used to treat cancers, that are known to help prevent cancers as well. An example of that would be serums, or what's called the selective estrogen receptor modulators, or aromatase inhibitors that are routinely used in breast cancer, can also prevent breast cancer in women at risk. It opens up the consideration of a risk-reducing surgery, like a bilateral mastectomy. And I can tell you those surgeries have become much more acceptable with significant improvements in reconstructive techniques and less aggressive surgical techniques for mastectomy. Maybe some of you have met women who have had skin sparing, areola sparing, even nipple sparing mastectomies. For GYN cancer, for ovarian cancer, there is still no proven screen that decreases mortality from ovarian cancer. And so risk-reducing removal of the tubes and ovaries, which is called a salpingo-oophorectomy, is still something that's commonly employed, and you wouldn't know to offer it unless you picked up the mutation. And then there's the concept of pancreatic cancer screening, which can be done in a more invasive way with a scope, what's called an ERCP, or with a type of MRI looking at the pancreas called MRCP. Let's talk about ovarian cancer screening risk reduction. A good ovarian cancer screen is the holy grail that we've all been looking for. Ovarian cancer is one of those diseases that if you pick it up stage 1 or stage 2, it has excellent survival. The problem with most ovarian cancers are that they are a type called high-grade serous cancer, and that specific type is much more likely to be picked up at stage 3 or 4 because of a lack of really identifiable symptoms, or less more vague and nonspecific symptoms, I should say, because they do cause symptoms in the early stages. So 70% of patients are picked up advanced stage. And so screening has not been found to be effective in ovarian cancer. So risk reduction becomes all the more important until you have an effective screen. And you can do risk reduction not just through risk reducing surgery, as I mentioned, but also medically. Oral contraceptive pills have been known for years to significantly reduce the risk of not just ovarian, but uterine cancer as well in patients who are picked up who are high risk. What we've learned is that we think that many women who have this disease that we've been calling ovarian cancer, it's quite possible now that it did not start in the ovaries. Because we're doing more risk-reducing surgeries, we're getting a chance to see what are the earliest changes that are happening in the ovary that lead to cancer. We didn't have that insight before. And surprisingly, we're finding that many women with ovarian cancer, it was the fallopian tube where the cancer likely started. And in fact, it's this distal end of the fallopian tube that biologically seems much more likely to cause a cancer than any other site. Now, you can use this new information to devise new ways of doing cancer risk reduction. Because right now, what the common recommendation is to take out someone's tubes and ovaries. The fallopian tubes have a major impact, obviously, on someone's fertility, although there are assisted reproductive techniques that get around that, right? You can do in vitro fertilization and bypass the need of the patent tube. But you're still taking out a younger woman's ovaries and the impact on her quality of life and her medical impacts with increased risk of osteoporosis, increased risk of heart attack and stroke. They're significant. But the newer concept is that possibly we could just be doing a risk-reducing salpingectomy when they're younger and possibly going back for a second surgery later to remove the ovaries. That would preserve normal ovarian function. So risk-reducing salpingectomy is an area where there's a lot of interest, but it is still experimental. There's studies going on trying to figure it out. It's obviously got the pros of preserving normal hormone function and the subsequent benefits in regard to a woman's quality of life, her cardiovascular health, and her fertility. The cons about just assuming that this is safe is that it hasn't yet been established in BRCA 1 and 2 patients, although trials are ongoing, and it does require a second surgery. If you take the tubes out first, you do have to go back and take out the ovaries later, and the impact of a second surgery hasn't been fully vetted. So while those studies are ongoing, I encourage anybody who's considering it to look into those clinical trials so that your clinical experience is then collected and can help answer this question. And women who decline removal of their ovaries can consider risk-reducing salpingectomy. I would say even off of a clinical trial, it can be done off of a trial for sure. And then there's something called an opportunistic salpingectomy. This means you were there in a woman's pelvis for another reason. And you can then, and this woman is not considering future pregnancy at that point, you can take out her fallopian tubes. And opportunities are presented at the time of a surgery for fibroids, surgery for ovarian cysts, surgical sterilization. Instead of tying somebody's tube, just take the whole fallopian tube out. And then there's other types of surgeries that aren't even GYN that it could be considered in, like a cholecystectomy or an appendectomy. So I'd like to move on to show you the power of multi-gene panel testing compared to that single gene testing that we were doing. And I want to give you the example of this woman with breast cancer who underwent genetic testing in the year 2000. And at that point, only had BRCA 1 and 2 tested, and she was found to be negative. Her concern is that her mother and her maternal grandmother both had breast cancer. And so, just by family history, she would come up as increased risk, even though you don't have a known hereditary syndrome going on. She's got two daughters and a son, and she's got grandchildren, and she's concerned naturally that if there is something that could be tested for, she wants to know. Well, if you repeat the genetic testing and with a multi-gene panel, you might find that yes, she is negative for BRCA1 and 2. It's part of the panel. But you may have 10 additional breast cancer genes in that panel that you could potentially pick up a mutation. So in this case, you might find out that she has a PALB2 mutation. This was not available in her testing in the year 2000, but you pick it up now. That gives her this risk estimate. She's got a 40 to 60% increased risk of breast cancer, 3 to 5% risk of, I'm sorry, not increased risk, a 40 to 60% risk of lifetime risk of breast cancer, 3 to 5% ovarian cancer risk, 5 to 10% pancreatic, and about a 1% risk of male breast cancer. So this woman who was saying I'm negative on genetic testing really is not negative on genetic testing. And so it's important to consider genetic testing not as a one-time thing in a woman's life, but something that needs to be revisited. And I do this often with patients who have had family history and have been tested. You have to ask them again to give you their test results to see, is the testing they did some years ago still considered the best that can be offered today? And maybe we can do better. Because that woman with the PLB2 test, she's got 2 daughters, a son, and grandchildren, and that allows them the opportunity to test. And in this case, her daughter, her son, and 2 of her grandchildren test positive for the PLB2 mutation itself. Not only does it give you more information and the power to act for those family members, but think of the relief it gives to those who test negative as well. For those who test positive, it gives you the ability to better use breast MRIs, risk-reducing surgeries, and to incorporate pancreatic cancer screening into their care. The other thing we have to think of is it became that woman's responsibility to tell all her family members that she has a mutation and they should be tested. Many times I have patients who are newly diagnosed with a cancer themselves, find out that they are positive for a cancer predisposition gene, and now we're expecting them to reach out to family members to notify them, sometimes in the middle of their own cancer treatments. It's a lot to expect of a patient. And one of the innovations, and again, here's a easy use of tools we already have that can extend the benefit of genetic testing significantly, is something called Cascade or family genetic testing. You start off with the first patient who tests positive. This woman tests positive for a BRCA1 mutation. Could be a man. And they have a number of people in their family who are potentially at risk. The way Cascade testing is that the doctor's office takes over the responsibility of notifying the potentially affected family members to offer them genetic testing. If those family members are found positive, they then have options for all those increased either enhanced screening or risk-reducing surgeries that can increase the likelihood of their lives being spared. So in the real world, most relatives never undergo genetic testing. This is part of the reason why I showed you in the first slide that the majority of people at risk don't know they're at risk. And that's a really expensive missed opportunity to prevent cancer. So assisted cascade testing through outreach and navigation has been shown to be effective. One of my colleagues, Dr. Melissa Frey, has done really groundbreaking work in this area, where she has shown that employing a system that allows the doctor's office to be the one to reach out to patients, and once they've decided they want to be tested, genetic testing can be done with saliva these days. So these folks can be sent a diagnostic kit for a saliva test at home. They don't even have to come into a physician's office. And what she found, Dr. Frey, is that in her assisted cascade testing program, uptake of relatives testing with a clinician facilitated approach, she went from a baseline of 35% of at-risk family members testing to 70% testing. Significant improvement. So, in conclusion, about a quarter of people in the general population warrant genetic testing just based on a history and family history and other things that can be used for formal risk assessment, they would be at increased risk. Many will have mutations of family history that warrant cancer prevention. And cancer screening and risk reduction interventions in many situations have shown to decrease the incidence of cancer, morbidity, and of course, the most important thing, the death rate from that cancer. But most patients remain unidentified. And it's because most providers are not offering cancer risk assessment. There are tools available that exist to facilitate cancer risk assessment, and family testing is critically underutilized and can result in lives saved. So the thing I'm hoping to have gotten across to you in today's talk is that if you're meeting with your physicians, you have family history or other things to suggest that you may be at increased risk of cancer, and no one is asking you these questions. No one has suggested genetic testing. Advocate for yourself and just ask, have you done a formal cancer risk assessment? And if your doctor feels uncomfortable doing so, just make sure you get in the hands of doctors who do feel comfortable and will get you the testing that you need. It could save your life, it could save lives in your family. And again, I want to thank the Ovarian Cancer Research Association for the opportunity to bring you this information. And I hope it makes a real difference in your life and experience. Thank you.